to make her thesis award presentation on a prospective study to evaluate incidents and indicators for early detection of ethambutol toxicity. Dr. Sohini, you can share your screen, and I would want Dr. Shobhit Chawla and Dr. Giridhar to briefly comment after she finishes her talk. I want the timer to show to all of us. It's not visible. You could start, Dr. Sohini.
Good morning, one and all. Myself, Dr. Sohini Mandal, Senior Resident in RP Center, AIMS, and my PG thesis title is a prospective study to evaluate incidents and indicators for early detection of ethambutol toxicity. So to begin the story, in 2019, India notified 24 lakh tuberculosis patients with an estimated incidence of 199 per 1 lakh persons, accounting for about 26% of the global burden that poses a huge concern for the community. Ethambutol, an integral drug of ETT, has the additional risk of drug-related toxic optic neuropathy. If not picked up early, can result in variable and often significant visual dysfunction. Thus, detection of visual impairment at an early and subclinical stage is critical. With the aim of elimination of TB by 2025, the RNTCP was revamped in 2016 with changes in the protocol for the management of TB cases. The 3 times a week regimen was changed to a daily regimen and was included both in the intensive and as well as the continuation phase. Therefore, greater duration and frequency of ethambutol administration is likely to be associated with higher incidence of subclinical damage, which brings us to the rationale of this study. The primary aim of our study was to evaluate incidence of toxic optic neuropathy in patients receiving ethambutol for 6 months on a daily basis, along with identification of early indicators of toxicity secondarily. It was a prospective observational study conducted at RP Center in collaboration with the Department of Pulmonology and DOT Center, AIMS, New Delhi. We had a mandate sample size of 50 TB patients. Baseline ophthalmic evaluations were performed prior to starting ATT and thereafter every 2 months till 6 months of therapy. Parameters assessed were best corrected visual acuity, color vision, contrast sensitivity, Humphrey visual fields, pattern VER, and spectral domain OCT to evaluate peripapillary retinal nerve fiber layer and macular ganglion cell inner plexiform layer thickness. We included newly and definitely diagnosed category 1 pulmonary or extrapulmonary tuberculosis patients aged more than 18 years who were advised treatment as per the new RNTCP guidelines. Of 50 patients enrolled in the study, the mean age was 36.4 years and the mean total body weight was 67 kg. Based on the weight, the mean daily dose of ethambutol administered was 17.5 mg per kg per day. None of the patients revealed any significant changes for BCVA, color vision, contrast sensitivity, and visual fields. Hence, the incidence of clinical ethambutol optic neuropathy in our study was less than 2%. The changes in VER latencies were statistically significant. However, the changes in the VER amplitudes were not significant. Loss of peripapillary RNFL thickness was statistically significant in all quadrants on consecutive follow-ups, and similar results were seen in GCIPL thickness in all sectors. Among 100 eyes, 46 eyes showed an increase in VR latency of more than 2 standard deviation, that is more than 125 millisecond at 2 months or 4 months follow-up, indicating subclinical toxicity. Thereafter, we compared the daily dose of ethambutol, mean and sector-wise GCIPL, mean and quadrant-wise RNFL thickness at 6 months between the eyes with and without subclinical toxicity. Patients who showed subclinical toxicity were on higher daily dose of ethambutol than those who did not. The group with subclinical toxicity was also found to have significantly reduced RNFL thickness in the temporal quadrant only and significantly decreased GCIPL thickness in the supraronasal and inferonasal sector only as compared with the group without subclinical toxicity. To conclude, the incidence of clinical ethambutol optic neuropathy was less than 2% in our study, with almost half patients showing subclinical damage in the form of increased VER latency. Patients receiving higher dose of ethambutol in the same weight band showed more subclinical damage, particularly involving the papillomacular bundle. Delayed VER latency was noted to be the indicator of subclinical. I just want to inform the House about the recommendations regarding prevention of ethambutol-related blindness as issued by the Ministry of Health and Family Welfare recently, primarily composed of 3 things: to increase the awareness, identification of high-risk individuals, and baseline examination of the aforementioned population. At the outset, I would like to thank AIOS for providing me a platform to present my thesis.
Thank you very much, Dr. Sohini. Could I have Dr. Shobhit and Dr. Giridhar commenting?
It's a very significant study, and there have been 2 previous studies from Korean groups. One was presented in 2016 in RO and showed exactly the same findings. What is significant is and one from the Calcutta group, that was in 2021 only, that was a bigger sample size of 93 patients. The number of patients we see with late stage ethambutol toxicity, so the clinical application and scientific value of this study is very relevant. With a simple device like RNFL, which is present in most of the clinics, VEP pattern may not be there, but it definitely has a significant value. I would request Dr. Giridhar to give his comment now.
Dr. Giridhar?
Thank you. I'm very much here. I would like to ask one or two questions. I mean, a nice study, very important study. Personally, I felt the sample size is very small. I mean, 50 patients in a disease like tuberculosis, especially in a tertiary referral center, I feel if you could have got a larger data, it would have been the impact would have been very significant. This is more of a pilot study, I would say. Number two is, now when you see the subclinical changes, what are your take-home messages? I mean, what do you conclude from this? What are the take-home messages, and what is the advice that you would like to give to ophthalmologists who are screening patients for ethambutol toxicity?
So my take-home message will be that since the new guidelines has been issued by the RNTCP, according to the guidelines that is issued by the WHO in 2016, which has increased the ethambutol dosing to a daily regimen, that too for both the intensive and continuation phase for 6 months.
No, that's not what I want. That's not what I want. Based on the results of your study, what you would like to say? I'm not bothered about what the national TB program tells.
Yeah, clinical application.
At both the physician level as well as the patient level. According to the physicians, the physician should
see a large number of your patients had subclinical. Nearly half of them had asymptomatic VEP changes, isn't it? Now, whether this sort of a change will, with that, I think, is it necessary for us to advise physicians that these patients have got early changes, subclinical changes, and whether these patients, the dosage has to be reduced or any changes have to be made in the treatment? That's what I would like to know. Because the idea of screening is to detect a toxicity before it becomes manifest or causes visual loss. So when you see a subclinical change, what is the significance of that? I would like to.
So first, we have to identify whether the patient belongs to a high-risk category or low-risk category. If the patient belongs to a high-risk category, then the patient is advised to undergo baseline ophthalmic investigations such as color, contrast, visual acuity, visual fields, VER at baseline and after every 2 months of.
No, you're not anywhere answering. Thank you.